thank you all so much for giving up your evening to join Rob and I tonight. So my name is James Booth. I am a GP. I do my clinical work in Chelmsford, but I'm also an LMC medical director in Cambridgeshire and the named GP for safeguarding for Mid and South Essex. And we're going to cover adult safeguarding tonight and some particular topics therein. I'm going to be working tonight with my colleague, Rob Walker. Now, as there are a lot of you on, Rob is going to be manning the question bar tonight, so you won't really see him, perhaps right at the very end when we do a sum up, but he will be answering all of your questions throughout tonight's session. So do please keep them coming. Introduce yourselves in the chat, and please, any thoughts, comments, queries, reflections, we love to hear from you as we go through our webinars. And we've got a lot to cover tonight, so I'm going to crack straight on. I don't know if you just want to quickly say hello, Rob, just to let everyone know that you're here.
Yeah, many thanks, James. Yes, a fantastic warm welcome from me too. Just brief introduction. Yes, my name's Rob Walker. Like James, I'm a GP. I work down in Hampshire 3 days a week in general practice, then spend the rest of my time with the Hot Topics team. But yes, I'll be manning the Q&A. Please do send any questions, comments, reflections as we go. It's always great to hear from you and learn from the virtual room. Right, I'll hand back to you, James, to carry on.
And we're also joined tonight by Glenn, who is running the presentation software. He'll be keeping an eye out for any technical problems that you might encounter. And do let us know in the chat if you have any particular problems. Often a quick refresh of your browser will solve anything, but Glenn is on hand for technical glitches. Now, what I'm going to say here is that we always want to start when we do a safeguarding presentation with a trigger warning. Safeguarding is an emotive topic, and whilst tonight's content isn't anything that should be particularly provoking, we all bring our own contexts and we all bring our own stories to safeguarding training. So do drop out if you need to, if anything's particularly upsetting, if perhaps it reminds you of a particular difficult case or something in your family life. Seek support if you need it, and just perhaps be mindful of those experiences of others if you're interacting in the chat or bringing any questions forward. So what are we going to be doing tonight? We are going to look at two key adult safeguarding topics. So we're going to look at mental capacity, which is an ethical issue, but which is governed by law. And we're going to look at the legal framework of deprivation of liberty safeguards, something that we all, or almost all of us, will encounter throughout our career. And I suspect most people on the call tonight have more than a few patients in their nursing home settings who have a deprivation of liberty safeguard applied to them. So we're going to look about the application of those in everyday clinical practice. Now, what we also want is to recognise the importance of these topics, because these are governed by GMC guidance. Duties of a doctor talks about our assessments of mental capacity and how we apply ethical judgments and how we work with the law in this field. And also, these are covered in the new RCGP safeguarding standards, still referred to by me as the new standards. They're over a year old now, but the predecessing document had been around for so long, I think I'm going to be calling them that for some time. Where these were a massive change from what went before is these are all-age safeguarding standards. They apply to everyone who is seeing patients in a general practice setting. They're very detailed, quite aspirational in their content, but this is a key part of the adult safeguarding material covered in those standards. And this webinar will help you work towards meeting those. And they talk very much, rather than having the old-fashioned idea of having to get a certain number of hours of training done each year, these are very much about the ongoing learning that we all do throughout our careers, recognising safeguarding as a golden thread that runs through every consultation with patients of any age, And that's very much the sense that we want to deliver our safeguarding training. But adult safeguarding has always perhaps been overlooked historically compared to child safeguarding. Perhaps that's been because child safeguarding makes the news more often when it goes wrong. Most of us can remember and recall the names of a few children who've had serious safeguarding cases, but the adult cases perhaps are less famous. There's also different legislation about them, less legislation historically. And we also now, as I've said, we need to recognise the need to use the all-age lens here. However, there is a lot of this. 640,240 adult safeguarding concerns were raised in England in 24-25. That is a 4% increase from the previous year. 185,270 inquiries were commenced under Section 42 of the Care Act, and those are broadly equivalent to the Section 1747 inquiries that you will see when you are dealing with children. And most commonly, these relate to neglect. And that's one of the reasons why we're putting this context in today around capacity and around the safeguards around protecting people from their own neglect of themselves, the neglect of others. This is a really key part of adult safeguarding work. And as I said, all of us will be encountering these scenarios. So these are our topics for the evening. They are governed primarily by the Mental Capacity Act. As well as legal, we have ethical considerations, and the GMC talks about these in Duties of a Doctor, and they are a key learning objective in the RCGP safeguarding standards. And so we're going to start with a few questions for you. So, answers please. Which of the following statements are true? Deprivation of liberty safeguards apply to people who lack capacity, who live in their own home. Capacity assessments are decision specific. Only a doctor with specific training to do so can assess capacity in an adult. A fundamental principle when assessing under the Mental Capacity Act is the presumption of capacity, and deprivation of liberty safeguards governed by the 2005 Mental Capacity Act. And let's see what your answers are to those questions. Now, just responding to one question that has come up in the chat, I noticed, just while we're doing some answers here. This presentation does focus on DoLS. So liberty protection safeguards, which apply to 16s and above, are being phased in. In practical terms, the DoLS framework is still very much active, and in my experience, this may vary from other areas. Because of its particular setting in nursing homes, we are still seeing an awful lot of patients under deprivation of liberty safeguards, and that's why we've covered this. It covers the majority of the work that's out there. But the LPS process is coming in, and this may be something we cover in future presentations, but I just wanted to cover that off while we were doing some answers. The process is supposed to be a little more streamlined and more universal, but we are still seeing DoLS very much in use, despite the legislation now being slightly older. And I think, as with all things, the pandemic rather delayed the implementation of them, as the LPS framework first came in 2019 with changes in the law. So, answers. Let's see. So, DoLS only apply to people who are in a hospital or nursing home setting. They do not apply elsewhere, and that's a key difference with the liberty protection safeguards, which can apply anywhere. So DoLS only apply in a hospital or care home setting. Absolutely, capacity assessments are decision specific, and it's also the case, absolutely right, that any doctor can assess capacity in an adult. Now, capacity assessments can be difficult, but there is no particular mandated training in order to be able to do one, and certainly any doctor is able to make an assessment of someone's capacity. The presumption of capacity is a fundamental principle of the MCA, and we'll come on to that shortly. And it is absolutely right. The Mental Capacity Act is what covers deprivation of liberty safeguards. So I've just put that in just in case we had a problem with our software, but because Glenn is running it, we didn't. So let's talk about our first patient, Mary. Mary is 72 and has been admitted to hospital following a fall with a fractured neck of femur. She lives alone. She has lots of chronic health issues. She's got really poorly controlled type 2 diabetes. And so a little bit of the bane of the life of your practice nurse when she comes to see her. But she does come to see her at times. She's fiercely independent. She doesn't have a care package in place. And she has capacity and will refuse a lot of the assistance that you offer. So she's known to social care but doesn't engage particularly well. She's a widow and has no children, but she has a network of family. She has some nieces who regularly help her and a collection of friends who will call in. She's something of a community figure, in fact, and quite well known in your local area. So she is obviously admitted with her fractured neck of femur, but unfortunately, when she's in hospital, she develops a post-operative lower respiratory tract infection and tries to self-discharge because she becomes confused. There is probably a sense that Mary would have tried to self-discharge anyway, knowing Mary. But an urgent authorisation DoLS is put in place by the hospital, so they realise that she cannot safely leave. They assess, probably correctly at that point, she does not have capacity to make that decision. However, when it's time for her to go home, the hospital apply for a standard authorisation to her DoLS. They feel she lacks the capacity to decide to go home, and the best interest assessor wants some information from you as her GP. So these are the sort of requests that come in and can sometimes make our hearts sink a bit on a busy on-call day. This is not going to be an easy one. Any thoughts in the chat about what you might want to be asking for, what you might want to be looking for here in terms of information about her? What kind of things are you going to be bringing out? What can you add to this as her GP? So keep your thoughts coming. I'll pick them out of the chat as they come in. But in terms of the sort of things that I would be interested in thinking about here with Mary is, what do I know of her wishes? What do I think she would want? What do I know about her medical history? Is this likely to be a transient loss of capacity, or is this something that's more likely to be permanent? I might want to reflect on my knowledge of her. I think I'm probably, given that, as people have said, is looking at her previous wishes, her previous memory assessments that you've probably done in this context. Has she had delirium that's passed before when she's had infections? This is where USP as GPs come in, and I often talk about this in our safeguarding material. Our expertise as GPs is in our patients themselves. And what we have here is a patient who we know well, so we might know who her next of kin is. We've probably had conversations with her and with her next of kin about her care, given that she's frail. We probably are aware that she would have strong views about hospital, because I suspect we've probably had the conversation with her before about trying to get her to go in about her diabetes when she's refused. And we want to know, essentially, in the capacity, of course, is specific to decisions, it's specific to that time, but our assessment of her capacity is not based on whether she's making a wise decision or not. And as we will come on to later, we can't just take health information into account. We have to take the wider biopsychosocial picture into account. So we're going to come back to Mary at the end of this, but I'd just like you to keep her case in mind, and we're going to talk about another case in a minute. So Jerry is 81. I should point out at this point, we have an account with a stock image company to get images of patients. it was really hard finding images for this talk of frail elderly people. They're all very glossy and photogenic. So Jerry is a resident in your local residential home. Now, he moved there from a rural home where he'd always been very independent. So he is never married, he's never had family. He has always been an eccentric person, but he's got no history of mental health issues, no history of dementia. But he's challenging to look after in the home. He's not harming anybody. He's not being aggressive. He's being quite cantankerous, perhaps a bit verbally difficult. But he will only eat a very limited repertoire of foods, which he says are the only things he likes. He doesn't like washing much. He likes to wash in the sink. He doesn't like baths or showers, and he's not big on changing his clothes because, again, he's never really wanted that. He doesn't like noise. He doesn't like entertainment. He just wants, to be honest, to be outside a lot of the time or in his room. He's very reclusive. And someone has put in the chat, could this be someone with undiagnosed neurodiversity? And I suspect a lot of the Jerrys of this world indeed were. So what he tends to do is leave the home for long walks. Now, he can do it. It's a care home. He's not a prisoner there. And he will refuse meals outside of his very limited tastes. And you're getting a few calls about whether he needs Bresolin because all he's really eating is cheese sandwiches. But there have also been a couple of police calls. The home have worried about where he's gone, worried it's got dark. He is a man of 81, and they've called the police. And on one occasion, the police have picked him up and brought him back to the home. Staff wanted DoLS in place to keep him at the home. And a few quite distant relatives have come out of the woodwork about him and have said, we think he needs to be kept here as well. So he is going to need an assessment of his capacity. So what sort of things would we be talking about here for Jerry? So he's clearly unhappy. There's clearly an unmet need here, or at least the way his needs are being met is not suiting him. And I agree, coming from a farming family, he does sound a bit like a typical farmer. And there are, what we want, and as we'll come on to this as well, in order to lack capacity, he would need to have a diagnosis to say that he does lack capacity. That's very true. These are the sort of patients where it can feel like the easy way here is this is an odd elderly man who's probably making poor decisions. He probably shouldn't be wandering about at 81 completely unchecked if he's becoming a bit frail. But we need to be considering, again, that wider biopsychosocial sense of his capacity. What is the story of his life? What is he wanting from care? What actually are his diagnoses here? So again, I'd like you to keep Jerry and Mary, our cases, in mind as we go through this. We have got another case scenario coming up. If you have any particular thoughts about them, let Rob know, and we will come back to do a sum up of them both in the end once we've gone through the topic. So, care versus control is the inherent tension we face in safeguarding work. We have a need to balance support and personal autonomy, and doctors should be all about support and personal autonomy. This is what we believe in as doctors. We are in a caring profession. We want to support patient choice. We recognise that patient choice is paramount, as it absolutely should be. But we also have to balance that when we safeguard people with interventions to prevent harm. And sometimes those interventions need to be legal interventions. This is a big deal. This is something that can represent some of the hardest work we have to do. And it is really difficult when protecting someone involves infringing their freedoms, because this relates to some of the most fundamental rights we have. We all have the right to make our own choices in life. We all have the right to move freely about our environment, to choose what we eat, to choose what we wear, to choose how we occupy ourselves. And if we are going to limit someone's choices, we have to do that with the proper safeguards in place the proper legal framework to make sure that we are doing so correctly. It's not easy, and we would never pretend that it was. Sometimes these decisions can be some of the hardest, most challenging decisions that we face, and they should be. We should never take this lightly. I think one of the great advances in medicine that's gone a bit unheeded in the last, certainly the last 50 years, and really since I've qualified in the last 25 as well, is the move away from paternalism. And certainly in the past, the Marys and Jerrys of this world were treated in a very paternalistic way. We don't do that anymore. That's absolutely right and proper. But it can sometimes be quite easy to move back into that particular mental frame of mind. And it's really, really important that we don't. And the processes we're going to talk about are what prevent us from doing so. So, mental capacity can be very simply defined. Mental capacity is simply the ability to make a specific decision at a specific point in time. That is all it is. And it is the ability to make a decision. There is nothing in the definition of mental capacity that states what the decision has to be. That's vital. It can be assessed by any doctor. The GMC is very clear on this. And there is a difference, of course, between assessing capacity in general terms and being asked to assess capacity for a specific thing, which it might not be sensible for a GP to do. So there are some circumstances where you might indeed want a detailed expert assessment of capacity. So one of the things, certainly in LMC land, we advise GPs not to get involved in testamentary capacity, your ability to decide whether to make a will or not and how to make it. But absolutely, in terms of capacity to make decisions about your healthcare, we can assess those decisions, and that's really important. In law, there is always a presumption of capacity. That applies to every single patient. The onus is on us to be assessing capacity against accepted standards and documenting that, and then deciding whether it's lacking or not. We always assume for every patient that they have capacity. It may be that your documentation decision making is very straightforward for a patient. This patient has severe advanced dementia, is non-verbal and non-responsive. That's absolutely fine. This patient does not have capacity to make their decisions. But we still need to start from that position of presumption of capacity and bringing that round to it being the ability to make a specific decision at a specific time. You may not have capacity to decide whether you can safely leave the residential setting you are living in, but you may absolutely have capacity to decide what you want to eat that day or whether to eat it or not. And that's also really important. So the first question to ask, if someone says, can we have a capacity assessment, is what is the decision? So the first thing we need to do if we are assessing capacity is address any issues that can impair that assessment. So what are the reversible factors here? Now, this could be something as simple and straightforward as, can the person hear me? Do they need the hearing aid in? Is this setting conducive to assessing this properly? It may be something more complex. Is there an intercurrent infection, for example? How am I communicating? Do I need an interpreter? Reasonable adjustments must always be made in capacity assessment. The Mental Capacity Act uses a functional assessment which focuses on the process of decision making. So if you are happy that you have made the reasonable adjustments that you need to make that could be impairing your assessment, then you need to have, one, an inability to make a decision. So this person cannot make a decision. Not this person is making the wrong decision, I think, but they can't make a decision. Then there must be an impairment or disturbance in mental functioning. Now that is quite loosely defined. So that could be organic. It could be related to an underlying developmental disorder. It could be related to a brain injury. It could be temporary or it could be permanent. But there has to be some evidence of impairment or disturbance in mental functioning. So, for example, if you have a patient with no pre-existing diagnoses, then that presumption of capacity would kick in. And there must be a causal link between the two. Because this patient has Alzheimer's disease, they cannot make a decision to leave their place of living. Because this patient has Lewy body dementia, we need to be prompting them for their feeding and encouraging that 3 times a day. That's the kind of thing, the thought process that you should be thinking about. And if you are following those steps and documenting that, and you are exercising your good faith professional opinion, you shouldn't run into difficulties in this regard either. So a patient can be deemed as lacking capacity if they can't understand the information relevant to the decision, they can't retain the information to make that decision, they can't use the information in making a decision. I've had a patient who we had quite a difficult capacity assessment to make on, where it felt that she was making decisions. In fact, she wasn't. She had very fixed, quite delusional beliefs about her health and just repeated them. She never retained and weighed up the information. There was never any evidence of a decision-making process. She just reflected back to you her unusual health beliefs. And they can't in any way communicate the decision. That last one is difficult because, of course, there are some patients who have, for example, severe dementia, who will never be able to communicate. But if you're dealing with a patient who, for example, has a neurodisability, you would need to make all reasonable steps to communicate with them, however that patient might be able to communicate. It presupposes that you have given all appropriate support to help them make a decision. And this is fundamental. You can have capacity and make unwise or even dangerous decisions. The decision you make has no bearing on your capacity to make it. So you cannot say, for example, in the case of Jerry, it's clearly ridiculous this man wants to go out at night for a walk. He doesn't have capacity. He is allowed to make bad decisions. We're all allowed to make bad decisions. Many of us chose to become doctors. So this is clearly evidence that decisions can sometimes be unusual and difficult. If an assessment is refused, so if a patient will not engage in your assessment, and this is a question that does often come up actually, it's how can we get this in our safeguarding team quite a bit. I'm not sure whether this patient has capacity or not because they just won't talk to me. They're refusing to engage. So you would need to make efforts to explain the consequences of that refusal. And you can make a reasonable assessment based on the information you've got if you have a patient who is not engaging. And indeed, it wouldn't surprise me if the Marys and the Jerrys of this world, looking back at our cases, these are the sort of patients who might indeed take a view on whether they were going to engage with your assessment or not. It is vitally important that you don't make assumptions. It's really easy to do so, and all of us, because we're all human and because we make observations as doctors, we are all potentially prone to making assumptions about capacity, about how someone is presenting. You never make a capacity assessment on the basis of age, on the basis of appearance, unless that was particularly germane to a diagnosis, of course. Unusual behaviour does not mean you lack capacity. There is no specific condition that automatically means you lack capacity. A decision the patient has made previously does not alter their capacity assessment at that point in time. And you should never make a decision on capacity on information from others alone. Now, the information you get from next of kin may be a vital part of your reasoning and your overall assessment, but you should never allow someone to make that decision for you, be that a next of kin, be that other family or friends, be that the staff in the residential home or the staff on the ward. If you are putting your name to that capacity assessment, it is your decision ultimately. You take information from others, but the decision would rest with you. So here's another scenario. This one is absolutely a true story as well. Elderly patient with severe dementia is resident in a nursing home. This is back in early 2021. They're at risk of complications and death from COVID. They have respiratory comorbidities. They cannot consent to the vaccination. How would you act? Let's see if we've got any thoughts about acting in the comments box here. And bear with me, just while you're thinking, I'm just going to duck under my desk to plug my laptop back in because I've knocked the cable out. Can't find the cable, we should be fine. So the sort of questions here is, this is someone who can't consent. So what we're going to look to see here is, has this person left us any information that might enable us to think about what their decision might be? Do we have anyone we can ask? Do they have a lasting power of attorney? Have they left any directions, any advanced care decisions that they might have made? So there is clearly a best interest decision that you can make here, but we should be taking steps to see what this person's wishes would have been and whether there is anyone indeed who is empowered to make that decision for them. So there are quite a lot of case law and indeed Supreme Court judgments on this. The Mental Capacity Act refers to best interests when taking decisions on behalf of someone who lacks capacity. So if we are making a decision for someone else, anyone who is making a decision for someone else, then we must be acting in the best interest of the person who lacks capacity, not the best interest of anyone else. And that should be the broadest sense of their best interests, and that's where a Supreme Court judgment came in. So it's not just medical considerations, it is psychosocial ones. We cannot just make this a straight clinical decision. This has to be in the context of that individual patient, and luckily, that is what GPs are really good at, putting clinical decisions in the wider context of the patient. This is also really important. Lacking capacity does not mean non-participation in decisions. Even if your patient ultimately lacks the capacity to make that decision, they can still express their belief. They can still express thoughts, reflections about that decision. That's particularly important in patients who, for example, have a learning disability. They should be involved in decisions about themselves. No decision about me without me applies to people who cannot fully make decisions as well. So best interest decisions can be very straightforward. If you have a patient who has fractured their neck of femur, absolutely giving them pain relief is in their best interests. There is no possible interest for that patient not to receive morphine if they have a broken hip. That's an easy one. But they can be highly complex. Some of these decisions indeed have made national news regarding what someone's best interests might be. And there are those of us in the audience who doubtless will remember the Tony Bland case, who was one of the victims of Hillsborough who had a persisting brain injury. That was a medical ethical issue that made headline news. The Charlie Gard case, who was the very unfortunate infant who had a mitochondrial disorder, and there was a lot of very public dispute between his parents and his doctors. That was also a best interest decision being taken in the interest of that poor child. So you need to think about the past and present wishes of the patient. Is there an advance directive in place? Now, advance directives often don't have any legal standing, but they can absolutely be used as a consideration of what that patient's wishes might be. What you know of the wishes and values of that patient. So if, for example, you knew a patient had very particular health beliefs, it would be reasonable to bring those into your decision-making process. Views of family and friends are important, but you do need to bear in mind confidentiality. That still applies, and we mustn't assume that someone who lacks capacity automatically loses their rights to have their information being kept confidential. And anyone the patient has previously directed to be involved. If you know about those people, then you might want to think about speaking to next of kin. You might want to reflect on how they might inform your view. So back to our scenario. There is clearly a medical best interest here. It is in this person's best interest to have a COVID vaccination. given the fact that what we know about the COVID in nursing homes. But you consult the family and the patient's daughter agrees the vaccination should be given. We would like mother to be protected. Please go ahead and proceed. And the nursing home staff are keen for the patient to receive that vaccination. Now, that would, at that point, be absolutely, I think, adequate for you to proceed. But we are going to come back to this scenario shortly, so please bear this one in mind. But at this point, you've got a medical best interests decision, you've engaged with the family, you've engaged with the people looking after the patient. This would be a green light to go, in my opinion. So it's often a bit dry talking about legislation, and the Mental Capacity Act is a long and dense piece of writing that you don't need to know in intimate detail. But you do need to know about it because this is the legislation that governs these matters for adults. When it comes to children, there is an overlap between 16 and 18-year-olds now in law, but the Children Act would apply as well. It applies to decisions taken on behalf of those who lack the capacity to make them for themselves, whether temporarily or permanently. A medical decision is lawful under the Act if the decision maker has a reasonable belief that the individual it pertains to lacks capacity to make it, and that the decision is made in their best interests. So that's a really important point for our COVID vaccination scenario here. You have a reasonable belief that the individual it pertains to lacks capacity to make it. You have made a decision that is in their best interests, so it is lawful to make that medical decision. Importantly, for medical treatment, it doesn't apply just to the treatment, but it would apply to matters alongside it. So, for example, if you were considering, for example, surgery on someone who lacked capacity, you have to think about the matters alongside it, such as the admission to hospital, the care afterwards, and so on. You consider the issue in toto. It's not just, should this person have that specific procedure? In practice, you generally would, I think, but that's an important point of law to make. It's important to note that valid advance decisions or decisions made by someone with a lasting power of attorney do take precedence. So if a lasting power of attorney for health makes a decision, that would take precedence over the Act. So that decision becomes the legally valid one. And if someone has a valid advanced directive, then that would also take precedence. If you have a scrap of paper written on the back of an envelope and you're not entirely sure whether the patient wrote it or not, that is not a valid one. It needs to be in the correct legal framework. So the Act also covers DoLS, and there is a statutory code of practice that comes alongside it. Now, interestingly, where this issue can become a little bit challenging is that there is a wider international set of legislation around supported decision-making. Now, this doesn't apply, the UK, the Mental Capacity Act would take precedence, but there is sometimes a little bit of tension legally, and this would really only apply probably to some quite high-level cases that would be going well beyond the level of our practice. But this is a piece of legislation that is not, it's not universal throughout the world, and that's quite important. And the supported decision-making concept can sometimes produce a little bit of tension with the Act, although I'm not going to dwell on that. That's a whole separate topic in of itself. Lasting power of attorneys. I've highlighted in bold here a few common misconceptions about lasting powers of attorney. So, the Mental Capacity Act has a provision for someone with capacity to nominate others to make decisions on their behalf in the event of them losing capacity. Once you have lost capacity, you cannot apply an LPA. You have to make the person who the LPA is going to apply to has to make the decision for the LPA to be in place in advance when they have capacity. Now, sometimes solicitors will write letters to you saying, can we have a report to say this person has capacity to make an LPA? Now, you are not contractually obliged to do that. A solicitor can make that assessment of capacity. If there was doubt, you may need to take specialist advice, and that is not an uncommon solicitor request in GP land. There are two types: property and affairs, health and welfare. The former can be used, so property and affairs LPAs can be used when someone still has capacity. The health and welfare LPA can't be used if the person still has capacity. So if you have a frail person in a nursing home who still has capacity, absolutely their family can use their property and affairs LPA to manage their money for them. But if they want a decision about medical treatment, the patient has to make it. Donors can restrict, and donors in this sense is the person who is the LPA will be about. They can restrict certain decisions being made for them. So, for example, if you were wanted to make a decision to say, I want to have a DNA CPR, that decision stands, that is my decision, I do not want that changed by anybody, then that decision can't be overturned if you have legally restricted it in your LPA. That's not a particularly common thing in my experience, but it does happen, and that's an important legal consideration here. They have to be registered with the Office of the Public Guardian to be valid. If someone, and the Office of the Public Guardian will be able to quickly tell you, if you contact them, if one is, but if they're not, if they're just written on a sheet of paper that the family have written down, they are not legally valid. You may still choose to use them as evidence around your capacity assessments and your best interest decisions, but they are not legally binding. There are also some valid enduring power of attorneys still around. The numbers are gradually shrinking as people get older, of course. These only apply to financial decisions. So if someone says, I have an enduring power of attorney about my mother, that has no standing in terms of making health or welfare decisions. It is purely about financial decisions. So, and again, just to reiterate, a non-legally binding living will, it can be reasonably used as evidence of wishes, but it has no legal power. You have to be registered with the Office of the Public Guardian. So, the Mental Capacity Act makes clear that people who cannot consent for themselves should be treated under the principles of less restrictive care. There will be times when appropriate, necessary care can only be given alongside restricting someone's liberty. So DoLS only apply in a hospital or in a care setting, and doing so is only lawful if authorised under the MCA in accordance with DoLS or a court order. And as I mentioned before, we are now seeing liberty protection safeguards coming in. They are being phased in. It's been, in my experience, certainly quite slow. The fundamental ethical principles around decision-making, whether capacity is present or not, still absolutely apply. The process from the point of view of medical information and the application for this doesn't actually change an immense amount, and we may well revisit that newer legislation at a later time. But most of your patients who are having their liberty restricted will be under DoLS, I suspect. Always seek advice. This is complex stuff, and your local safeguarding team will be able to advise you. Your indemnity organisation will be able to advise you. There are lots of sources of support if you need it. No one is expected to be a particular expert on the legalities around this. This is a multi-professional action, and it's not one in which the medical profession takes a lead in the application, but we do provide critical information around them. So, care involving a restriction of liberty is not necessarily inappropriate. That is a fundamental principle here. So, and it is worth saying, because it does sound perhaps obvious, but that is an important point here. Just because you're restricting someone's liberty, it does not mean you're acting inappropriately. You can absolutely act in their best interests. But enacting any kind of restriction of liberty should neither impede or substitute the best possible care. So the best possible care must be given to that patient, and the decision follows that. Nothing in the MCA will prevent the delivery of timely and necessary treatment. Now, that's important. And just as an aside here, I'm conscious that in the 4 nations, the legislation does differ slightly. The principles of the law are constant. The ethical considerations are constant. I have to confess, perhaps displayed a bias towards English and Welsh legislation here because we wouldn't want to go into the details of every little bit of law, but the principles are universal. If you see someone who needs timely and necessary treatment, if you visit the nursing home and someone is lying on the floor with a fractured neck of femur, if someone is bleeding heavily, if someone needs an acute intervention, you absolutely are authorised, or it is legally appropriate to give it. Of course, that does not necessarily apply to resuscitation because, of course, DNA CPRs are separate. But timely and necessary treatment can always be given in someone's best interests. A DoLS does not authorise treatment in its own right. So it just refers to the restriction of the liberty. It does not authorise treatment. So if you have a patient under a DoLS and they need to have a medical treatment decision, that is separate from that. It should always be used in best interests if there is no alternative in the least restrictive way. And that is true for any legislation anywhere that restricts someone's liberty, be it this, be it Liberty Protection Safeguard, be it the Mental Health Act, all of those things. Best interests, if no alternative, and in the least restrictive way. So the MCA doesn't actually define what deprivation of liberty is. There is some case law. So is there continuous supervision and control of the person? Are they free to leave? And do they lack capacity to consent to their care and treatment at the present time? If so, then a DoLS or an alternative must be sought. The managing authority, that would be the hospital or the nursing home, will apply to the supervising authority, which is the local authority. The person would have an appropriate advocate, and the authorisation can be standard or urgent. Urgent DoLS are for decisions where someone might need, like, for example, trying to self-discharge from the ward in our case earlier. Interestingly, if you have a severe illness, so you need immediate care to prevent death, that is not a deprivation of your liberty. There's a Supreme Court ruling about that. So even if you're brought into hospital to treat your severe illness and you are confined to a bed, that is not a deprivation of your liberty per se. It doesn't need that safeguard applying. Effectively, you can always treat somebody in an emergency in their best interests. Cheshire West, 2014, if anyone's interested in reading it. So, going back to our vaccination scenario, the daughter of the patient consents to the COVID vaccination, but before you give it, the son rings up. I don't want my mother to have that experimental, gene-altering, terrible vaccination. I've read about these COVID jabs. It will kill her. I absolutely refuse for my mother to have this. If you give this to my mother, I will sue you. And if she dies, I will make sure you lose your license. Both son and daughter are named in the LPA. They will not meet together to discuss this, as becomes no surprise when you've had the conversation with them. They are estranged from each other. So her son says, you give her that jab, it will kill her. I will hold you accountable. I forbid you from giving it. The daughter then says, if she dies of COVID, I'm going to hold you accountable and sue you. This is a real scenario. Probably this happened more than once, but this is a real case. Any thoughts on what you would do? Who would resolve this? I won't pause for too long for the answer here, because you are going to need the Court of Protection to sort this out. Now, this is just something for you to be aware of. They were set up to oversee the implementation of the Mental Capacity Act. They rule on validity of LPAs and what they mean. They can approve treatments. They can declare on capacity and best interests. They can also appoint a deputy to make decisions if there's no existing attorney. That can be a family member or an independent person. They can order a Section 49 report to gather information. So they have quite a lot of legal powers. If you had a case that was going to the Court of Protection, this is something that you would be very much supported through. I hope by your local safeguarding team. Certainly there would be legal representation involved. So it's something to be aware of. These are the decision-making body, but you would access them probably through social care in these scenarios. So in that case, the COVID vaccination was given. The Court of Protection ruled in favour of the daughter, and the lady in question had her COVID vaccination, as you would expect them to rule. So Mary was independent but frail lady at home. She got a lower respiratory tract infection following a fractured neck of femur, had a DoLS in place in hospital, but they wanted to continue the DoLS and discharge her under it to the nursing home. So this was the lady who you knew well. She was independent, she had capacity in your experience, an eccentric widow with no children, but she had some nieces who helped and generally was quite contented with her lot, much as it might have been a lot that a lot of us didn't really understand. So GP attends discharge planning meeting. Absolutely get in today's straitened, difficult times, this is really hard to do. We are all under immense capacity strains in general practice at the moment. But if you can get to a discharge meeting, and I have done this for patients, if you can reflect your knowledge, in this case of her independence, her family support and her care network, then you can help support the decision being made in the right way for this lady. And in fact, in this case, she accepts the care package, which she had previously declined, having recognised that her injury had been a serious one. She was supported at home following discharge and actually did rather well. She is based on a real patient of mine where this happened. In fact, the key bit of information I had at her discharge planning meeting was that I knew she was illiterate. She never told people that because she was highly embarrassed about it. But that information was really important in terms of supporting her discharge and how some of the conversations on the ward had gone, because they had her assessment of her capacity had been impacted by the fact that she had poor literacy. Jerry was independent, possibly elderly farmer living in our nursing home. Eccentric behaviour, often leaves for walks. He'd had a police call a couple of times. Home wants a DoLS for him. Now, this isn't about convenience for his caregiver. This is about what he wants, because you have assessed that Jerry has capacity. He's got no mental disorder. There is a suspicion that he might be neurodivergent, but he's never had a diagnosis. He is not making anyone unsafe. So with Jerry's input, a plan is drawn up with his participation to help maintain his safety. Fundamentally, he can leave if he wishes, but there are agreements around restricting his walks to daylight hours, giving himself an understanding with the home about brief information about where he will be going and when he will be back. His eating habits, he's allowed to eat what he wants and so on. And in fact, the home support his safety, keep an eye on him. Things settle quite well for Jerry. And indeed, is this not the retirement that many of us would want? I have to say that whenever I do my nursing home visits, I'm always secretly quite gratified to see someone who is being a little cantankerous and pushing against the limits a little bit. One interesting case I had at my own nursing home that I looked after, we had an elderly couple who formed a relationship, a very loving relationship within the home, and wanted to make that a physical relationship. And it caused all kinds of consternation with the nursing staff, and we had to say to them, these are two people who absolutely have capacity, are making a very free decision, and as long as they are acting with privacy and discretion, absolutely they should be we should all be entirely happy for them to be making that decision for their own life. But good Lord, that one did make the staff nervous. We had many a call about that one. So this is complex. We absolutely get that this is complicated stuff, but it is also everyday general practice, and much more everyday general practice, I think, than we sometimes realise. So it's vital. Mental capacity is based in law around fundamental principles. It's governed by the MCA. Court of Protection oversees the enactment of that law. DoLS are vital safeguards for the liberty and safety of patients, and they are gradually being superseded by different versions of the law, liberty protection safeguards. But whatever the form of law you are, whatever the legal mechanism is, the fundamental ethical principles, the framework that you will be using to make those decisions, that is unchanged. We've just got a little survey here for you to fill out while we're just summing up. Rob, do you want to bring up any key points, any questions or reflections I'm conscious that we're running close to 9 o'clock now.
Thank you very much, James. Yes, I'll just dive in just for a minute or so, just to wrap things up. First of all, thank you very much for all your brilliant questions, comments and reflections. It's such a tricky area, this, isn't it? I think we make decisions on capacity, every day in our clinics, isn't it? And, 9 times out of 10, it's very straightforward, but those tricky ones are really difficult. And I think the things for me just to remember, and I think this has been a theme that's come up a lot in the questions today, is when we're thinking about capacity, is just to remember some of those first things that James said, that capacity needs to be situation and time dependent. You can't just say somebody does or doesn't have capacity. They can only have capacity for a particular decision or area at a particular time. So those sorts of decisions need to be reviewed on a regular basis, depending on the situation. And ultimately, there's always the presumption of that people do have capacity until proven otherwise. DoLS, as James says, again, tricky area. Many of you have been involved with this. Interestingly, some of you being involved apparently in some community DoLS type programs, which I wasn't aware of, DoLS in the community, and I have seen that come through. But yeah, if in doubt, I think for me, one of the other take-home messages is, you've got colleagues around you, you've got your safeguarding teams, you've got your LMC. So if in doubt, do make sure you take advice from them if there are any tricky decisions, because it's not very easy. James, I'll just hand back to you for a final wrap up, but thank you very much, everybody, for your excellent questions.
Yeah, thank you so much, Rob. And thank you very much to Glenn for keeping us running in the background. None of us at MB Medical would be able to do any of this stuff without the excellent technical support we get from Glenn and his colleagues. Thank you all so much for joining us this evening. I think I'll just finish on that note from Rob. There is always someone to ask. It's an important job. Speaking as an LMC doctor and a named GP, I love hearing about these in both of my roles. But your MDO will be able to help. Never struggle through these in silence. We all recognise these are really difficult scenarios. But at the same time, there are some quite simple principles that if you follow, you will be staying lawful and you won't be going far wrong. Thank you all so much for joining us this evening. There will be a certificate coming up soon in the programme, and we would love to hear your feedback. Any thoughts, any comments? And if there's anything specific you'd like to bring up about this material or any other issues, I'm james@mbmedical.com, and I always love to hear from anyone who's attended one of our courses. If you've got something else you'd like us to cover in the future, comments on this, please let me know. But with that, I shall let everyone go and have a well-earned rest for the rest of their evening before we all go back to fray tomorrow. Thank you so much for joining Glenn, Rob and I tonight. We hope this has been useful, and we look forward to seeing you again very soon on another webinar.